Hi everyone, and welcome to this EHMA webinar on COVID. This series, this episode is on European hospitals and COVID-19. Specifically, we'll be looking at Italy today, and the theme of today's is reacting and adapting. So that in terms of how we're going to run this webinar, we've got a the first thing is that all your microphones are muted, and that's just to keep the audio clear so you can all hear us clearly, and so these run a bit more smoothly. Next, if you want to raise questions at any time, you can put them in the chat box. I can see that already someone's, my colleague Federico has chatted in the chat box to let you know where that is. So feel free to add any of your questions or comments there at any point during the presentation. As I mentioned, we record all of the webinars and you can find them on our website. You can find the last 3 that we've done, and as well as some news about our future webinars. So I'm George Valiotis, I'm the Executive Director at EHMA, and I'll just be facilitating today. The agenda that we're going to use is, as I mentioned, the title is Hospitals and COVID. Firstly, we'll look at how COVID is affecting and reshaping hospitals, and secondly, how they are preparing for a second coronavirus wave. We'll have a 15-minute or 10-minute presentation, and then 15 minutes of question time at the end. So really think about your questions. It's a great chance to talk to each other and to hear directly from the speaker his ideas. So our speaker today is very lucky to have Professor Federico Lega. He's the president of EHMA and also a professor of health administration at Milan University. Federico, thank you so much for joining us. I'm going to hand over to you now to start your presentation.
Thank you very much, George. Hope everyone actually can listen to me, can hear me well. So thank you, everyone. So what I'm going to do now is try to share with you some of the lessons that we learned in Italy over the last 3 months about what really impact of the hospital and the hospital system because of the pandemic that we have to manage. I guess everyone knows that Italy have struggled for a bit, for a few months in coping with this emergency, but at the same time, the stress we put on the hospital system was really useful because we learned several things actually that reinforce some of the thinking that we already have about how we should change hospital and the hospital system itself. So that's why I start with these slides. What we really learned is not so new, but it really give us a more strength in the direction we were already looking for in terms of how reshaping or reconfiguring the hospital network in the single hospital. These are the 3 major, and you can see from this slide, there are 3 major paths of change that we've been pursuing over the last 20 years almost. First one is bridging, generating basically connection networks among the different hospitals. There's a misspell, I'm sorry about this, bridging, obviously generating bridge among hospitals. Second one is redesigning, trying to reconfigure internally hospital, making them more patient-centric. Now we will say a value-based hospital. And third one will be engaging, so making clinicians more accountable to one extent and more committed to help the management of the hospital. So what we learn is that the COVID experience really relaunched to some extent the work we've been doing on these 3 areas, and I'm going to show you how and why we have some very good insights about what health policy could actually learn and make as a top point in the agenda for the next month. First one, we really have, again, a confirmation of the relevance of creating multi-hospital networks, okay? What happened in this country, like in other countries, we have to redesign the network, identifying the COVID hospital versus non-COVID hospital. So we really have a major effort in planning, making a hospital up for COVID and trying to keep other hospitals clean so we can have the typical or the already planned or scheduled activity going on. Second, we learn how important could be having a quick move of patients among different hospitals or between 2 hospitals. And that actually goes back to the idea that if you don't have a strong institutional rather than strategic networks among hospitals, this is not easy. COVID actually put a lot of pressure on this. We have patients move from one hospital in our system, from one hospital in the region to even other hospital in other regions, so very long transportations. But what we learn is the fact that without generating a real network, having some governance of the hospital network, we will lose some opportunities for the future of developing a much more sophisticated and effective hospital system. And third, we also have an increasing experience of what we call the pendulum of physicians, which we're moving among different hospitals. So the same physician will work 2-3 days a week in one hospital and then the other 2 days in another hospital. So we're sharing competences. We have a COVID hospital where the first hospital where we actually started admitting COVID patients, that then they basically lend their physicians to the other hospital and they exported the competences and skills in other hospital, good practices. So what we learned from this experience is that if we really want, we can move to the next level in terms of generating within health system good hospital networks, and there's a lot of opportunities behind that. So what I do expect is that the emergency managed by most health system, by all health system in this period will give us more directions, even more strength in pursuing even better the creation of effective multi-hospital networks within health systems. This is a great opportunity. Second major area where we had an impact, obviously, was redesigning. Okay, most hospitals were challenged to internally redefine the layout and most of the logistics. And what, from my viewpoint, what we finally have is really a true experience of what we usually call a patient-centered hospital, because we need actually to redesign hospital during the COVID emergency in order to accommodate for patients' needs, which means we have very unstable patients, but also we have stable patients with the disease or with the virus, but also we have the other patients still actually knocking at the door, at least part of them knocking at the door because they have acute problems rather than chronic conditions to be managed. So what we learn is the fact that we will have to design hospital in the future much more according to patients' needs rather than the typical functional organization based on discipline, on specialties. We will need to have hospital with a large eye care area with some flexibility inside, which means goes from monitor beds to sub-intensive and intensive care unit all together in a single area, so that's actually we can manage better within it the allocation of patients according to the level of acuity or instability. We need to develop a low care acute stable patients area where again we need to introduce some flexibility in the utilization of beds. Many wards were relocated from original scope, which might be connected to a specific specialty for COVID patients. We learned actually we can even have physicians doing urology that can be basically assisting patients with internal, with medical issues rather than surgical. So we might have the need actually to think that in the future, hospitals need to be redesigned internally to have a multi-specialty area where we can allocate stable and acute patients, providing the level of flexibility that we need in order to stay in line with either the season peaks rather than the waiting list. We also learned that we need to introduce in every hospital a step-down units for post-acute patients, something that facilitates the continuum of care. So moving patients from the acute wards to the post-acute means also generating the flow and making then possible for patients to basically to be taken care better when it comes to discharge and finding the next level. We developed focus hospital. That's the idea that the COVID hospital within the hospital. Basically, some hospitals were basically managed in a way so that you have the rebuilding of the hospital within the hospital, and that's the concept of focus hospital. And we're trying to develop to take care of the multimorbidity, multi-chronic patients. And a lot of effort on introducing good patient flow logistics with operation management, making a big step forward in taking basically more responsibility in organizing the way we manage the flow, the different flows, the different paths of patients. So when I say redesigning that happened during the COVID phase of the COVID emergency, gave us back a number of indications that what we were trying to do in order to transform hospital toward a more patient-centric organization was actually in the good directions, and we can even accelerate in that respect. We need to design layout and logistics for flexibility. So every hospital which will be designed today for the future, every new hospital should actually have this principle and the basis. Nothing new, but now we have a clear idea about what we mean by generating one single eye care area, one single post-acute step-down area, and so on. And then, as already said, we have a key role for operation management and patient flow logistics coming into the picture. And the very last things that we learn, but this is probably even the most important from another perspective, because it goes back to the human side of health organization, right? We learned that clinical leadership really makes a difference. When it was about the beginning of the crisis and we generated the crisis unit within the hospital, we immediately start feeling that some clinicians, some clinical leaders were ready to cope with this and were ready actually to reorganize on a night or on a day basis their units. They knew how to do that. They knew how to motivate the other people. They were really executing great leadership, and they were a major asset in coping with this difficult times. So what we learn is nothing new to some extent, but it gives another rather say good confirmation that the effort we're doing in all health system to train some clinicians to become even better leaders in the interest of the organizations and become what we define as servant leaders, it really makes sense. Without them, it wouldn't be possible actually to manage a situation like this and probably cope with a much more uncertain and difficult future. Second, doctors discover that technologies like telemedicine, sharing data, and all the things that happen in this period can help to connect rather than, I said, remove from the patients. So they started to do this experience, and now what we expect is that because of the engagement provided by the COVID, we will have the opportunity to make this type of innovation in terms of how we deliver services through technology more a routine rather than exceptional things that sometimes happen on a pilot basis or project. So I think we have the ground to say there's no more excuses. There are areas like follow-up of chronic patients, like pro-acute conditions where we need to use this technology. This is good not just for the sustainability of the system, but because it really is effective when it comes to generating more continuum of care for patients rather than the sense of trust that they have that the system is taking care of them. And third, doctors also learn that business modeling can improve a lot designing service delivery. We contaminate some of the doctors during this period and say, well, in order to restructuring or redesigning the way service is delivered, you have to think about your targets, what are their needs, what typical, what expectations they bring within the service, or what specific clinical rather than organizational needs they have given their conditions. And then you have to build a portfolio of services, simple as that, and how the flow actually will take place from the acute to the subacute to the post-acute phases. So we started to use some of the business modeling approach within hospital much more than we did in the past. Say, reorganizing a hospital really requires that kind of attention. So what we expect is that one of the policy indications that we will have for the future is that all hospitals can actually make, again, another step further in becoming a little more managerial in the way they approach the organization of their service delivery, and doctors can be engaged. And this experience has been a big experiment in doing something like this. So these are the positive, really the positive side that I can see we can take from the COVID experience. Hospitals really been very, very stressed by the emergency, but they really we're subject to such an experiment that we need actually to take those lessons and put them back in the policy agenda and try not to lose the opportunities that actually we have from this period. George?
Terrific. Federico, thank you. That was fascinating. I have a bunch of questions for you. And if anyone in the room has questions, please can you type them into the chat box? That's at the bottom of your screen. If you look at the bottom of your screen, there's a few little tabs and one of them will say chat. So feel free to type your questions in and Federico will answer them right now. Federico, to start us off, I'm wondering, do you think that we can rely on the inertia from COVID alone, or do we need a specific type of leadership to get us to progress us further? And if so, if we do need some other special leadership to make sure that our changes from COVID do take place, where should that leadership be and what does it look like?
Well, that's the question probably from another perspective. I'd say we certainly have to, we can even learn a little bit about how to improve the governance of hospital, okay? Because what we, again, if I look from a leadership perspective, what we learn in this case is the fact that when you have, in crisis period, obviously, they always been using in managerial environment to generate this type of reaction. So when you have a crisis, when you have a specific scope, organization works better because they know actually what they're working for, right? So what we learn is the fact that it's not just a matter of generating leadership skills within the clinicians, but it's also providing them with a scope and ambitions for using that leadership within the hospital. So I think the real lesson that we need to learn, and that's from, it's a lesson for the management of hospital, is that they need to provide a similar situation for the future, not a crisis, obviously, but an ambitions to develop their hospital so they can engage really the clinicians in using their leadership skills, their leadership capacity for the hospital. If we lose this, if we go back to the situation which hospitals are run according to the daily basis activities or just as a routine, it doesn't work that way. So I think this is a big lesson from it. So clinicians, when they do have a clear scope and motivation for doing things, they really step forward and do things incredible they didn't do during the ordinary days.
Right, amazing. Okay, so we've got a question from Mickey Koo. If you look at the chat box, you'll see that she asks, what would you say would be the percentage decrease in managing non-COVID patients?
Sorry, but what is exactly what do you mean by the percentage decrease in managing? What is the...
Mickey, if you could maybe elaborate on your question
yeah.
And while we wait for Mickey to answer that, I would say my other question to you, Federico, is you work between academia and practice, so you equally kind of are between the two. Is there anything that we could also do to improve the linkage between academia and practice, like other opportunities that COVID is teaching us that could improve that relationship?
Well, I guess when you look at the connection between the two environments, what I usually find is the fact that academia is often detached by the reality of words, because it's been very much impressed by this idea that publish or perish. So everything that can be published not necessarily is useful for the practitioners. And on the other side, practitioners sometimes, because of that, they feel that it's not worth even to read what is written by academia. So I think this crisis could be actually a good starting point to re-elaborate in a different way the connection, because obviously the academia, if they want to write something about the COVID experience, they need actually to go back and put their hands right on the shop floor of organization. So that might be an opportunity to make the academia more actually keen to really study effective issues or real issues within organization. And on the other side, it might do a good job for the practitioners if in doing this work, they provide the frameworks that then the managers, the leaders can take on as a way to do the work that we usually call reflective practitioners. So helping them to reflect about what they learned and what they did during the crisis. I have to say that I have a number of general managers came to me and say, why don't we have a conversation? They need to talk about what they did. They need actually to make sense. and whether they can bring home some lessons. So I think this is the opportunity that I see in this phase. This is a really great experiment for everyone to do things in to the next level in terms of connection.
Okay, great. So Mickey has clarified their question
yes,
by saying.
Oh, okay. Yes. Yes. We saw. We already saw there's been a decrease. Another very interesting thing, Mickey, that came out is the fact that emergency room basically become desert. Okay. So we during the COVID phase, no one was showing at the emergency room. Only we had a major trauma because they actually happen sometimes, but it was unbelievable. So that goes back to the point that probably a big chunk of the things that we do in emergency room on a daily basis is not really appropriated from a clinical viewpoint, because people didn't die, and obviously there are some people that just postpone some activities, some medical activities. But we started to learn something very interesting about also the fact that there are incredible space to improve the level of appropriate care. But going back to your question, yes, certainly there's going to be a decrease. Patients are afraid, especially the elderly. The elderly are the more actually afraid of going to the hospital because of the message, a lot of the fuss that the media put in the discussion. But the things that, going back to what I said before, the things actually the system need to do is clarifying that within their network, there's going to be a clear distinction between COVID hospital and non-COVID hospital, and they need to relocate activities from the COVID from the non-COVID, which means again moving physicians to do practice in other hospital. We have a very interesting situation. We have hospital COVID, which made agreement with the hospital non-COVID, are sending patients and physicians to do surgical activities and to do medical therapies there. So they basically lending part of the hospital to the COVID hospital. But that happens only when you start having institutional, or rather say, coverage for generation of strategic alliance rather than real networks by the health system decision makers. Okay, but certainly we're going to have. We estimate that we're going to back to normality in terms of demand by the end of the year, not before.
Thanks, Federico. We've got time for a couple more quick questions. There's one from Steve that, Federico, you could start to have a look at. And while you read that, Federico, I'll just ask everybody, I've posted a link to our evaluation form. It's really essential that we get evaluation responses from people so that we can know how relevant these are to you and what we could do to improve them. And it's a chance for you to give your feedback, and thanks to Federico as well. So please do copy and paste that link into your browser. It takes 90 seconds to fill it out. So the question from Steve is that Federico mentioned the need to improve business planning, including more relevant organizations' targets. What does this imply?
Yeah, okay, Steve, the question is very well posed. Thanks a lot. Yes, certainly. As I said before, I really believe that this experience actually gave us the opportunity to open a conversation with the clinical leaders about the fact that their responsibility is not just producing volumes or numbers, which certainly it is important, but it's also helping the organization to do, whenever it's necessary, a reconfiguration of business modeling, which is exactly generating a more coherent or connected thinking about how do you use resources, how do you connect those resources to the needs of the patients, how do you improve the patient flow within the hospital. So rather than having them thinking about that the issues is about having a budget and being responsible for a budget, is much more than having a budget, is using the budget to generate in a service, to generate an experience. So that's what we're trying to move. So clinical leaders are not just producing numbers, they're generating experience. If they understood that, they can use some of the methodology that was developed in other business environment, adapting them in an intelligent way into the health system and making a really step forward in generating patient-centered, patient-focused organization. So yes, that's what I see from my perspective as a great opportunity out of this crisis. And Sylvia, as well. Yes, so obviously, that's the thanks Silvia for the questions. Primary care physician was really the big issues we have in this country. The fact that they often are detached from the health system. They often work as a sort of an independent professionals rather than being integrated within hospital or other assistance. So what we learn is the fact that from a system perspective, we need to find ways to increase, improve, whatever, strengthening the governance of family physicians or primary care physicians within the system. They cannot be really, as we experience in this COVID emergency, individual or group practices without stronger accountability towards the health system. They really operated too much, rather say, in a sort of a I wouldn't use the word anarchy, but you work like Peter. Everyone actually was saying whatever they want. They were questioning whether the system was doing the right or wrong things, and that doesn't work the way. They're part of the system. They must understand they're part of the system, and they need to work to improve how the system works rather than questioning whether the system is working well or not. So what I'm saying is that it's good. You have an obligation to dissent in a system when things doesn't work. Things don't work, but primary care physicians need to be really integrated much better in our system. At least this is the experience in Italy, but it seems to me that it's not the case just for Italy, but also in many other countries.
Thanks, Federico. So yeah. Thank you for your answers, and thanks everyone for your questions. That's been a really great discussion. I'm going to just wrap it up here. If you do have any other questions on this topic, please do take a minute to copy and paste the evaluation form into your browser and give us a bit of feedback. You can ask more questions there as well. We really want to be connected to you, and we realize there are a few limitations in this online form in that it's a good way to give you information and let you tap in your questions. But if you want to join us for live discussions, then please become a member of EHMA. Think about coming to our conference in November. And we have a series of these webinars that happen every week or two. And we want to keep them as relevant to you as possible. We're really grateful to everyone for joining today. We know you're very busy, and we are very appreciative of the important work that you're doing in keeping European health services running effectively. And for those of you outside of Europe, we really thank you for your input and interest in what we're doing here. And we also welcome your expertise. So thanks everyone. Federico, it's really an honor to have you speak with us today. And if anyone wants to follow more information from Federico, you can find us on our social media that's on the screen now. And you'll also see him at our conference and maybe in future webinars. Thanks, Federico. Thanks, everybody.
Thank you very much, George. Thanks to everyone.
Bye.
Take care. Ciao, ciao.